Hi, my name is Don DeSalvo, and I'm the Director of Ultrasound Imaging at the Dana-Farber Cancer Institute in Boston, Massachusetts. And today I'll be discussing 3D ultrasound in oncology, dilemmas, drugs, and Doppler. So I have no financial disclosures, but I will say that I may have a tendency to produce somewhat misleading and perhaps provocative lecture titles. So if you're looking at this expecting to see a lecture on 3D volumetric ultrasound imaging, this lecture is not for you. Instead, I'd like to show how we use ultrasound as a diagnostic sort of problem-solving tool relating to patients undergoing chemotherapy, and so that's the drugs. The dilemmas are primarily related to liver and hepatobiliary disease, and Doppler is frequently a very useful adjunct. So as a oncology imaging specialist, we have basically three challenges that we face. We're looking at the primary tumor and their metastases and how they're responding to chemotherapy. And for that, we use CT, PET-CT, and MRI. But additionally, we have to be sensitive to intercurrent illness that a patient may have during the course of chemotherapy, and also from complications that could arise from that chemotherapy. And in particular, we'll be focusing on how ultrasound is very useful for this problem, particularly as it pertains to the liver and the gallbladder. So just a brief review of standard cytotoxic chemotherapy. The agents are here shown on this image, and these, while they have been very useful in treating oncologic problems, they carry their own side effects, and some of them can be diagnosed with ultrasound, including sinusoidal obstruction syndrome, such as we see here, or steatosis. But I'd like to turn our attention to the newer chemotherapies, so-called molecular targeted therapies. And these are things that are targeted to the cell surface receptors, and these include tyrosine kinase, such as we see with epidermal growth factor receptors, and those that target angiogenesis, the vascular endothelial growth factors. There are other therapies that target intracellular pathways, others that are primarily antibodies that are to surface receptors, and these are typified by bevacizumab and ipilimumab. So these are the sort of drugs that I want to sort of discuss and show how they can lead to secondary unwanted side effects. So this diagram here is taken from a piece authored by one of our GU oncologists, and it just shows the multiple levels of sophistication that we now have available to us in terms of treating either receptors along the cell surface with particular agents, or agents that are actually going to be working on all of the myriad intracellular pathways that can lead to unregulated tumor growth. So, brief case, why should we know about chemotherapy? So I want to just show you this, an example. This was a 45-year-old woman who had chronic myelogenous leukemia undergoing chemotherapy. And she was referred for a right upper quadrant ultrasound for some abdominal discomfort. So these are images from that study, and we can see that the gallbladder wall was rather diffusely thickened here on this sagittal view. On the transverse view, again, diffuse thickening and perhaps a little bit of sludge we can see here dependently. Images through the right upper quadrant, subcostally on the liver, showed a normal appearing liver, but incidentally there was some what appeared to be fluid in the right pleural space. Images of the left upper quadrant showed a large spleen, a normal kidney, but again, some fluid apparently in the left pleural space. So the official interpretation was gallbladder wall thickening, sludge, possible cholecystitis, and the bilateral pleural effusions were mentioned, but they were kind of buried in the body of the text and not brought out in the impression. Well, the patient experienced increased shortness of breath over the next several days, leading to this chest x-ray, which shows sizable bilateral pleural effusions. And so this was actually directly related to her chemotherapy of dasatinib. It was reduced, and her symptoms subsequently resolved, but she was able to be maintained on the drug, but at a lower level. So pleural effusions are not incidental findings in a patient who's on this dasatinib, and that's because this is one of these newer targeted chemotherapies that particularly acts against the mutant tyrosine kinase that's switched on all the time, leading to the unregulated cell division. But a significant side effect of this is pleural effusions. So it is frequently the limiting sort of side effect that relates to how much of this tesatinib can be given. And so it is important to be aware of this because you can still maintain the patient on this dose, but at a reduced level such that it doesn't cause pleural effusions. So if we now consider the big dilemma, abnormal LFTs and right upper quadrant pain, and we look at the so-called general population on the left-hand side, these are the diagnoses that we're all pretty familiar with. But if we turn instead to the oncology population, which is what we'll be discussing, these are the kinds of diagnoses we need to consider. Drug-induced cholecystitis, drug-induced hepatitis, portal venous air, tumor hemorrhage, and veno-occlusive disease or sinusoidal obstructive. So these are the things we're now going to look at more closely. So once again, just to review, the conventional chemotherapeutic agents are shown in this table with the name and then the type of mechanism, which tumor it's used for, and some of the adverse side effects. And then if we turn to the molecular targeted therapies, which is what we're going to be spending most of our time with, again, laid out in a similar fashion. And I want you to point out some of the ones we'll be looking at closely at: bevacizumab, causing steatosis and bowel perforation and pneumatosis, erlotinib or Tarceva, that can cause hepatitis, everolimus, which can lead to a calculous cholecystitis, and ipilimumab, which can also cause hepatitis. And I have to say that these two tables are a conflation of the three ultrasound related, or actually just radiology articles that are at the bottom of the screen. And these were two of them are actually coming from our institution, where we have a particular interest in looking for potential adverse side effects. So first up, drug-induced hepatitis. This is rather rare, a 5% incidence. The offending agents include tyrosine kinase inhibitors and also the immune modulators, ipilimumab. And I have to mention that immune modulators are now coming rapidly to the forefront as being the sort of major, newer attempt at targeted chemotherapy. Unfortunately, drug-induced hepatitis is a diagnosis of exclusion after we've sort of eliminated all the other possibilities that someone with a diagnosis of cancer can have for having abnormal LFTs. And it's really just proved by the fact that you stop the drug and the LFTs fall. But it would be helpful if we could actually have a positive way of making this diagnosis, because again, the key is we want to be able to maintain the patient on chemotherapy, but perhaps at a lower dose where it's still effective against the tumor, but not causing the adverse effect. So what are the possible imaging findings we can see with drug-induced hepatitis? Well, for CT, we would look for enlargement of the liver, some rounding of the contours, especially of the left lobe, which I'll demonstrate, periportal edema, perihepatic fluid, gallbladder wall thickening. In ultrasound, we would again look for similar findings. And as a matter of fact, many of these were beautifully elaborated as far back as the 1980s when we looked at the diagnosis of viral hepatitis. And frequently, the findings are going to be overlapping. So again, we'll look for enlargement of the liver, hypoechoic parenchyma leading to the so-called starry sky liver, gallbladder sludge or wall thickening, and then a new finding, which I've noted to be edema of the gallbladder fossa. So first case, a man with metastatic melanoma undergoing ipilimumab therapy, and his liver function tests are rising. So this first became apparent to us when we looked at the CTs, and I have to say this is an example of how CT taught us to look for some of the ultrasound findings. But if we look at his baseline compared to when he is coming in symptomatically, it's very easy to see. The liver has gotten larger, the spleen is larger. We can see this rounding of the inferior portion of the left lobe and a change in the angulation of the fissure for ligamentum venosum. A secondary finding is this little bit of hypodensity tracking along the left portal vein, which is periportal edema. Looking more inferiorly, again, the baseline on the left and the acutely symptomatic, again, note that the liver is larger, but we also see multiple small nodes adjacent to the pancreas. If we now look at the ultrasound that was done and where we didn't make the diagnosis, these are the things we see. So the gallbladder looks a little thickened with some sludge, nothing really specific finding there. However, if we look at the left lobe of the liver, this is a grossly enlarged left lobe, and here is that sort of extra rounding of the inferior edge of the liver that I think can be a very useful sign for knowing when the liver has enlarged. Another finding here, when we look at the porta hepatis, there was a normal common bile duct, but instead there was a lot of echogenicity adjacent to the porta hepatis. Again, this is the ultrasound correlate of the periportal edema that we saw on the CT scan. So these are the things we need to be sensitive to when we're trying to make this diagnosis using ultrasound. And this, matter of fact, now it's just a summary slide. This patient actually went on to have a biopsy, and the biopsy images are shown on the bottom. And this was confirmed as drug-induced hepatitis. The dose of ipilimumab was reduced. The patient's liver function tests abnormalities resolved, and he was able to continue on the chemotherapy. And this actually was written up again by my colleagues at the Dana-Farber. Another case, again, a 60-year-old man, metastatic melanoma, again on ipilimumab, and with a similar constellation of symptoms, nausea, vomiting, rising LFTs, but his ultrasound findings are actually slightly different. The only thing we saw when we looked at his gallbladder was right next to sort of the mid portion of the gallbladder. There appeared to be maybe some focal wall thickening, but there was no tenderness. However, when we look at this clip, we can actually see that the thickening is not involving the whole wall, but instead right next to it in so-called what I like to call edema of the gallbladder fossa, which is, again, just another manifestation of the diffuse hepatitis. And this was really his only manifestation. Another example showing the so-called starry sky liver, a woman with recurrent breast cancer undergoing chemotherapy, and again with abdominal pain and elevated LFTs. And here again, it was the CT that first tipped us off to it, and we can see again on these coronal images the gross enlargement of both the right and left lobes, as well as the sleeves of hypodensity indicating the periportal edema. And there was some patchy enhancement in segments 5 and 6. But then when we look at the ultrasound, and here's a clip kind of passing through, starting up at the sort of junction of right and left lobes, porta hepatis, and then going down into segments 5 and 6, we really made no observations here. But in retrospect, if you look at the periportal triads, particularly down here in segments 5 and 6, you can see that they are very echogenic. So this is, again, that periportal so-called edema, starry sky liver. All right, now I'd like to turn our attention to cholecystitis and the unique manifestations that patients undergoing chemotherapy can manifest. And this is, we think, is an acalculous cholecystitis. So generally they don't have stones. They, again, here these are some of the offending agents: tyrosine kinase inhibitors, sorafenib, sunitinib, everolimus, an mTOR inhibitor. And in all of these, we think that the mechanism is probably stasis or an atonic gallbladder, and this may lead to mural ischemia. And generally, the symptoms resolve and the gallbladder function returns when the agent is discontinued. So this was the first case, a 62-year-old woman with metastatic breast cancer to lung and bone on a VEGF inhibitor with right upper quadrant pain. When we look in the right upper quadrant with ultrasound, we see a gallbladder that's rather distended, has a lot of echogenic, apparently crystal-like sludge within the gallbladder. But if we look at the wall, it's very thin. It's less than 3 millimeters, and the patient didn't have a Murphy sign, just a little bit of right upper quadrant discomfort. Well, it was felt to be related to her chemotherapy because her gallbladder had previously been normal, so it was discontinued. She came back 1 week later feeling better. Her gallbladder starts to look better. Maybe there's a little bit of wall thickening, but all of that thick-looking sludge that was in the gallbladder is gone, just maybe a few little crystals. But because the drug had been so effective against her metastatic disease, the oncologists were anxious to restart, and they did. And 3 weeks later, she came back, and we have a very similar looking picture. Again, a rather distended gallbladder. But again, note that the wall is not thickened, but it is completely filled with this apparently immobile sludge. So we suspected that there was something interfering with emptying of the gallbladder, so we gave her a fatty meal challenge. And when we look here at the volumes before and after, we can see they're absolutely unchanged. So this again proved that this was just biliary stasis, and somehow the drug was interfering with gallbladder emptying. So basically stopped the drug and then just restarted on a lower dose, and the patient was able to continue on with her chemotherapy without any further symptoms. Another example of a cholecystitis, another woman, younger, with triple-negative breast cancer, metastatic. She had progressed on prior standard chemotherapy. She was now on a VEGF inhibitor. She came in with abdominal pain, nausea, and vomiting. So if we look at her gallbladder, it actually does have a similar look, appearing to be filled with sludge, but in addition we see this sleeve of hypoechogenicity, again, very reminiscent of what we saw with the hepatitis picture earlier. And this is, again, this edema that's around the gallbladder, in the gallbladder fossa, reflecting some hepatic irritation. And it's very easy to see when we do this sweep here that the gallbladder wall is actually not edematous, but instead it's all this edema of the fossa of the gallbladder. So this was this person's manifestation of hepatic and gallbladder dysfunction. This was the CT, and again, pre-contrast, very dense appearing material corresponding to the sludge. And this again is that diffuse edema surrounding the gallbladder. An additional unexpected finding was a small amount of free air up around the edge of the liver, and this was felt to probably represent an unsuspected bowel perf, which is, again, a not uncommon finding with many of these tyrosine kinase inhibitors. So the drug was stopped, and her symptoms in free air resolved in 2 days. Another example, elderly man, renal cell carcinoma on sunitinib therapy, begun 3 months previously with new right upper quadrant pain. And again, we see what appears to be a sludge-filled gallbladder, but this time the wall looks thickened, the patient has a positive Murphy sign, so this now elevates our concern that there's more going on than just gallbladder stasis. And in fact, when he had the CT, this was confirmed. We see diffuse stranding all around the gallbladder, some free fluid around the liver. And so based on these findings, the patient was treated with a cholecystostomy tube. He could not undergo a gallbladder resection at this time and antibiotics. And then ultimately 2 months later, he underwent an open cholecystectomy, and this was a necrotic gallbladder. So again, this shows that this parent stasis of the gallbladder can extend to finally include ischemia and frank diffuse inflammation of the gallbladder. And finally, this last case was probably the most extreme. 72-year-old man, esophageal cancer on many chemotherapies, including bevacizumab, the new VEGF inhibitor. And he comes in with new fever, white count of 15,000, and a very rapid clinical deterioration. And this was his baseline gallbladder from 6 months prior. And it looked like there were some stones, maybe a little bit of the patient had some ascites, but otherwise not a particularly remarkable gallbladder. Well, at the time of his symptoms, when we tried to find the gallbladder, it appeared to be completely collapsed. And here we've sort of drawn it out for you. Maybe there were still a few stones there. But when we looked just adjacent to it, we saw this unusual area of hypoechogenicity right next to the gallbladder. And then it's a little bit easier to see when we look at this clip. We can see this hypoechoic focus and then the gallbladder that's completely collapsed right next to it. And so this led us to be concerned, based on his rapid clinical deterioration, that this gallbladder had in fact perforated, and this was an abscess, and this was confirmed on the subsequent CT scan. Here we see the gallbladder with the frank perforation and the cholecystic collection in the liver. And so this patient was treated with percutaneous drainage and fortunately survived. Okay, now I'd like to turn our topic a little bit to portal venous air. We recognize portal venous air as, in 2 basic clinical settings. Those in which we're worried about a bowel ischemia or infarction, and these patients are usually clinically very, very ill, and it usually prompts an urgent surgical consultation. However, we're recognizing that some drugs, in particular bevacizumab, can cause a benign pneumatosis where actually air is seeping through the wall of the mucosa of the bowel into the wall of the bowel, and then ultimately leading to portal venous air. And there have even been cases of frank perforation and pneumoperitoneum in a small number of cases. And it's thought to be due to this anti-VEGF drug that's decreasing capillary density of the mucosa, leading to a microperforation. And generally these patients are treated with just simply discontinuing the agent, and usually these do not require any surgical intervention. This type of complication has also been found with tyrosine kinase inhibitors, mTOR inhibitors, and including some of the older agents, Cytoxan and steroids. And I'd like to show you an example of that. So this next patient had relapsed refractory multiple myeloma. He was undergoing chemotherapy, and because a secondary effect of the chemotherapy was to lower his absolute neutrophil count, dexamethasone, or a very powerful steroid, was added on 2 weeks prior to our seeing him. And he came in with new elevated transaminases and minimal symptoms, a little bit of right upper quadrant discomfort. When we looked at his liver, there was nothing particularly remarkable. Maybe it looked a little bit echogenic. It was kind of hard to see because he had a lot of perihepatic fat. But actually, if we look at this clip, we can see that there's actually little moving echoes within the portal vein, and this is actually portal venous gas. And again, an abundant amount of fat around the liver made the imaging a little suboptimal. And this was using a 4 megahertz. If we switch to a higher frequency transducer, we can see these bubbles really just jump right out at us. And that's a known, now that we're considering using contrast-enhanced ultrasound, it's known that if you image microbubbles with a higher frequency transducer, it'll make them much more conspicuous. And when we actually looked at the venous outflow, namely here the hepatic veins, we see these same little high density foci moving through, indicating that these gas bubbles had moved completely through his hepatic circulation and were now completely circulating back to the hepatic vein. Because the patient was minimally symptomatic, the patient was allowed to go home after consultation with the physician, came back 2 days later just to confirm our suspicion, which was that this patient had pneumatosis, and we were just happened to catch the air as it was passing through the portal venous system. And in fact, this topogram confirms that, diffuse pneumatosis. And here on these coronal recons with a bone window, it really brings out this extensive air within the wall of his colon. So at this point, there was no portal venous gas seen on the CT. We've actually re-looked at him again at this point with ultrasound, and it was completely gone. So again, because of minimal symptoms, patient's dexamethasone was stopped, and when he was re-imaged 3 weeks later, everything had gone back to normal. So again, a really dramatic representation of how what we used to consider to be a really dire predictor, pneumatosis and portal venous air, with actually a benign outcome. But we think it's due, again, purely to the chemotherapy causing a change in the mucosal integrity of the colon. I'd next like to turn now to examples of intratumoral hemorrhage and how they can lead to acute symptoms. And this was a 62-year-old woman. She had ovarian cancer with known peritoneal metastases around the liver, and she experienced sudden abdominal pain, and she had been on gemcitabine for the past 6 months. When we looked at her, we saw a large complex fluid collection indenting the surface of the liver at a site of a known perihepatic metastasis, and this corresponded exactly to where it hurt. And if we look at this sort of clip, we can see this large fluid collection, complex with strands, very, very typical for hemorrhage. And so this was an acute hemorrhage into a metastatic lesion. Her chemotherapy was stopped, and the hemorrhagic component was drained percutaneously, and then she was allowed to continue on with her chemotherapy. We can also get hemorrhage into pre-existing cysts, not only pre-existing cancer, and this was shown in this case, a 55-year-old man with colorectal cancer on standard 5-fluorouracil and oxaliplatin adjuvant therapy, and he had sudden right flank pain. When we look at this right kidney, we can see that, yeah, there's some echogenic foci and a little bit of dilatation of the collecting system, suggesting that he's formed some stones, and he has some stones. But the real cause of his pain is this exophytic cyst that has now developed a hemorrhage. When we turn transversely on it, we see this kind of amorphous, low-density, non-vascular, dependent clot. And here, as we sweep through it on this clip, it's got the very typical geographic shape of hemorrhage. So this, again, is a known complication of this drug. I'd like next to turn to a consideration of hepatic veno-occlusive disease or sinusoidal obstruction syndrome, which again we see with increasing frequency in our oncology population. Most important thing to remember is that this is not Budd-Chiari syndrome, but rather hepatic veno-occlusive disease. And what this is due to is to microscopic obstruction at the hepatic, sinusoid, and venule level, leading to portal hypertension. And that's why a better name actually is sinusoidal obstructive syndrome, or SOS, which is what actually now the preferred nomenclature for this syndrome is. So the clinical definition are patients present with painful hepatomegaly, jaundice, and ascites. So why is it important? Why should we consider it? Well, it occurs in two groups of patients: those that are undergoing or going to undergo stem cell transplantation for leukemia or lymphoma, and as part of the pre-stem cell transplantation regimen, they undergo this regimen with busulfan, cytoxan, and gemcitabine, and they have total body irradiation. And this somehow sets them up for this sinusoidal obstruction syndrome, but it usually doesn't manifest until 35 days after the stem cell transplant. So that's why it's important to know this person's history when you're examining them. The other group of patients of which we're now seeing it increasingly are those with oligometastatic liver disease from colorectal cancer. These are surgical candidates because of the low tumor burden in the liver, and they undergo neoadjuvant chemotherapy prior to the planned surgery to help shrink the size of hepatic metastases. And one of the usual drugs used here is oxaliplatin, and this is the drug that is known to cause this sinusoidal obstruction. So it's important to know, because if you're treating them and you don't recognize it, hepatic tumors appear to be shrinking, the patient then plans to go to surgery, he will then go into hepatic failure. So that's why it is important to know before it gets to this stage. So the ultrasound diagnosis of sinusoidal obstruction syndrome is challenging. There were multiple earlier studies that suggested Doppler or grayscale ultrasound wasn't sensitive or specific for the diagnosis of sinusoidal obstruction, but the problem was these were small population studies. So I'd like to share with you our experience with a large multi-center study of 140 patients who are undergoing defibrotide therapy for this very syndrome of sinusoidal obstruction. And here's the reference from our local group that performed the multi-center study. So just to review briefly the structure of the hepatic acinus, we see the portal veins, hepatic artery, bile duct out at the periphery, and then the hepatic sinusoids and the central vein. And if we look at the blood supply, again, the portal vein is most supplies and the hepatic artery supplies the rest of it. And these are the hepatic sinusoids. The blood flows down and ultimately gets to the central vein. And there are three separate zones of the liver that are defined pathologically. And it appears that the third zone, or the part that's furthest away from the richly oxygenated portal blood, is the most prone to any kind of endothelial damage, and that's presumably where this sinusoidal obstruction is happening due to the toxic effects of the preconditioning regimen, which interferes with the endothelium at this site, leading to obstruction. So there are two groups that define it clinically, a Baltimore group and a Seattle group, and they all basically have similar findings of hepatomegaly, weight gain, and ascites. So our particular protocol for trying to detect this at the Dana-Farber includes looking at the liver size, and we measure the left lobe in the mid-sagittal plane, and again looking at that similar finding of rounding of the inferior contour of the left lobe like we saw with the hepatitis cases. We also measure the right lobe in relationship to the lower pole of the right kidney. We make sure there's no biliary dilatation. We look at the gallbladder because frequently they will have edema of the wall of the gallbladder. And then portal venous flow is very key because what we're looking for are signs of portal hypertension, which is slow or even bidirectional or frankly reversed flow, especially in the left portal vein. It seems that the left portal vein is a little bit more sensitive to this. The hepatic venous tracings are not particularly useful in this, and then of course we look for ascites in Morrison's pouch and in the pelvis. So I'd like to show you two cases illustrating the key ultrasound findings of this syndrome. This first one was a young man who had acute myelogenous leukemia and had gone through the preconditioning, had his stem cell transplantation, and then post-transplantation began having weight gain and abnormal liver function tests. So here are images of the left lobe and right lobe, and right off the bat, we see that the left lobe is markedly enlarged. It spans almost 15 centimeters, and the lower margin of it is rounded, similar to what we saw in the hepatitis cases. The right lobe of the liver, not particularly enlarged, but there is some ascites, which is a key finding in this syndrome. Here's the gallbladder, completely filled with sludge, with wall thickening, not surprising. And then when we do the Doppler, we look at apparently a discordant finding. We look at the main portal vein, normally antegrade flow, but when we look at the left portal vein, it appears like it's reversed. We can see the two hepatic arteries tremendously aliasing, reflecting that the hepatic arteries are doing everything they can, but it appears to be that the portal vein is reversed. Well, how can this be? Really, the answer is shown when you do the pulse Doppler, and when we look, there is normal pulsatile flow in the main portal vein, but the left portal vein is actually biphasic, and there is transient reversal and antegrade flow. So this again is that early manifestation of portal hypertension seeming to manifest itself first in the left portal vein. So we made the diagnosis of sinusoidal obstruction syndrome, and this was confirmed with a subsequent wedged hepatic venous pressure tracings. And then the second case, an older man, again, chronic myelogenous leukemia, had undergone stem cell transplantation, again having increased girth, LFTs were rising. Starting out in the left lobe again, we see a very similar picture, markedly enlarged, spanning 13 centimeters. The left lobe in the mid-line of the, lined up with the aorta shouldn't be more than 10 centimeters. We again see that rounding of the posterior part of the left lobe. His right lobe looked slightly enlarged. It was hanging down below the lower pole of the kidney, and there was a moderate amount of ascites. And we looked at his gallbladder, again, diffuse wall thickening. We turn on the color Doppler, it looked like he had portal vein thrombosis. Here in the main portal vein, there's absolutely no signal in the portal vein, and we have nice signals coming from the hepatic arteries. But the important thing is to recognize is that patients with this syndrome they don't just suddenly reverse flow or develop thrombosis, the flow slows down. And so we need to be very, very sensitive to make sure that we're optimizing our Doppler color scale and particularly the velocity range. And here we're at what should be okay for a normal liver, 18 centimeters per second. But in fact, when we drop to 5 centimeters per second, we see, yes, actually there is antegrade flow in this portal vein. It is not thrombosed, it's just very, very slow. And then again, we can confirm this, we always do, with a pulse Doppler, and we can see again very slow undulating portal venous flow. We also have some aliasing coming from the adjacent hepatic artery, and this again reflective of the very slow flow. So this person is not actually frankly reversed, but is again experiencing the increased pressure in the sinusoids from the sinusoidal obstruction syndrome. So this was confirmed with wedge pressure. And this is where defibrotide, which is this newer agent that's being specifically developed to treat this complication, was successful and the patient recovered. So in summary, it's important to consider special diagnoses when you're looking at an oncologic patient who comes with abnormal liver function tests or right upper quadrant pain, and they should include thinking about drug-related complications of hepatitis, cholecystitis, portal venous air, intratumoral hemorrhage, or sinusoidal obstruction syndrome. And it is very important to know the patient's chemotherapy in order to make a timely and accurate diagnosis. I'd like to thank you for your attention.